Mr. Daniel, a 45-year-old gentleman who was recently discharged for an uncomplicated unstable angina, represented to emergency department within 2 weeks period. This time around, during assessment and ED, it showed that this gentleman has suffered from an extensive anterior STEMI and cardiogenic shock. Do you have any idea how could this happen? Or could we have missed out something in his last ECG? If you know the answers, congratulations. If you do not know the answer, that's fine, because we are going to explain to you along the course of this lecture.
I'm Dr. Tan, General Physician from HSTAR. Today we'll be learning about non-ST elevation myocardial infarction, also known as NSTE-ACS. I'm sure most of you may wonder what actually non-ST elevation myocardial infarction is. It's actually a new nomenclature designed to replace the older term unstable angina or non-STEMI. In order to illustrate to you, I have put up these front covers of our Malaysian unstable angina non-STEMI CPG. On my left-hand side, this image is actually the front cover of our unstable angina non-STEMI CPG, last published in 2011. As you can see, 10 years down the line, in 2021, which was last year, we have updated the CPG. At the same time, we have also changed the title of this CPG to non-ST elevation myocardial infarctions. These are the learning objectives. At the end of the lecture, you will know what acute coronary syndrome is. You will also understand the mechanisms of angina. And most importantly, you will understand the principles of ACS management, especially from the perspective of a non-PCI capable hospital where most of us are working in. And lastly, I will take you through the drugs with cardiovascular benefits. And we will end the lecture, as usual, by discussing some common missteps in the ACS management. Let's get the ball rolling by looking at our ACS definitions. Acute coronary syndrome is actually defined as a clinical spectrum of ischemic heart disease that develops because of an imbalance between myocardial oxygen demand and supply. So what causes an acute coronary syndrome event? It actually has multifactorial origin. Let us start off by looking at the most traditional or common belief how an ACS event happens. It was believed that ACS happened when there is a atherosclerotic plaque rupture, ulceration, fissuring, erosion, or there is atherosclerotic plaque dissection. So when this happens, it will result in an intraluminal thrombus formations in one or more of the coronary arteries. Ultimately, it will cause decreased myocardial blood flow, or sometimes it may actually cause distal platelet emboli. With the occlusions, it will cause myocardial necrosis. All this add together, it will give rise to a state of ischemia, and the patients will have ischemic chest pain that eventually we call this as an acute coronary syndrome. The mechanism that I have informed to you earlier can only explain an occlusive coronary artery disease. When you look into literatures, ACS really have multiple origins, and sometimes these causes may coexist together. For example, ACS can happen because of coronary spasm, therefore you have a condition known as a Prince-Maslow angina. Besides that, ACS can also be caused by microvascular dysfunctions that affect the coronary microcirculations. This diagram highlights to you very well. Our heart are not only supplied by these major coronary arteries, there is also an extensive network of microcirculations here. And lastly, myocardial endothelial dysfunctions can also give rise to an ACS event. All in all, I hope that you will understand now ACS management really need a multi-pronged approach, and revascularization alone is never a substitute for an optimal medical therapy. Under this ACS umbrella term, we have 3 conditions known as unstable angina, non-STEMI, as well as STEMI. So let's look at the differentiation between unstable angina and non-STEMI first. Then, of course, these 2 conditions shouldn't have ST elevations in the ECG changes. If there is an ST elevation in ECG changes, then it will be classified as STEMI. The differentiating point between unstable angina and non-STEMI is the cardiac biomarkers, in which the cardiac biomarkers, for example, like the highly sensitive troponin I, will be elevated in non-STEMI, but not in unstable angina. Like what I mentioned to you in the earlier slide, nowadays we would classify unstable angina and non-STEMI to be under this new nomenclature known as NSTE-ACS. Just like any other conditions, the management of conditions start by taking a good history. So what does ACS patients will commonly present to you? They will normally present to you with central chest pain, or sometimes the chest pain can be located at the retrosternal or the left-sided areola. They will describe the chest pain as tightness, heaviness, pressure, squeezing, crushing pain, or sometimes they will describe as having an impending doom. And the chest pain will commonly radiate to the jaw or down to the left arm. We should also elicit the symptoms of autonomic disturbance, because not uncommonly they will have this sweating, palpitation, nausea, and vomiting. And also lastly, some of them may also have the feeling of shortness of breath during this ACS event. Well, not all patients will present to you with typical ACS symptoms, so you have to beware when you are treating certain populations, like patients who are elderly, females, or patients with diabetes, who their manifestation of these ACS symptoms may be non so specific. For example, they may come to you with fatigue, shortness of breath, dizziness, lightheadedness, unexplained sweating, and sometimes syncope. So if that's the case, right, you really need to take a very good history. At the same time, if the rest of it will depend on your ECG as well as your cardiac biomarkers, in which we're talking about highly sensitive troponin I. Another point worth mentioning is that our latest CPG actually recommend the use of high sensitivity troponin I in diagnosing acute coronary syndrome or to rule out an ACS event. So in this context, let me show you this high sensitivity troponin I level that was being used by our hospital, HSTAR. The cutoff point for male would be 58, and the cutoff point for female would be 40 nanogram per liter. When the high sensitivity troponin I is elevated, it indicates that the patient has some degree or some form of myocardial infarctions or myocardial ischemia. But the caveat of this test is that it can be elevated in other conditions as well. For example, renal failure, sepsis, stroke, trauma, ARDS, pulmonary embolism, and also sometimes patients with myocarditis could have elevated troponin I as well. Ultimately, you need to have a very good clinical acumen for you to decide whether this raised troponin I is because of an ACS event or not. Or sometimes, not uncommonly, they will have a combination of both ACS event plus a non-ACS event together. Finally, we come to the main crux of the lecture today, which is to talk about how to optimize a patient's ACS treatment. The focus of the lecture today will be what to do after the patient admitted to medical ward, but I can just briefly touch on what would commonly happen when patients first arrive in our emergency department. First of all, you take a good history, examine the patients. You also do an echo assessment in emergency department. You send a baseline investigations. Then you will always need to institute the ACS treatment in the emergency itself before admitting to medical ward. So this diagram summarizes nicely to you the ACS treatment in a nutshell. It may look a bit daunting because it looks like there are many components in this management, but don't worry, we'll take you through one by one in the subsequent slides. When an ACS treatment has been established in emergency department, the patient will receive dual or double antiplatelet therapy, which consists of aspirin, as well as one of the P2Y12 inhibitors represented by clopidogrel or ticagrelor. Both DAPT agents have to be given in a loading dose at the beginning. For aspirin, we'll load the patient with tab aspirin 300 mg stat crush, then followed by 150 mg OD. You can also consider giving them tabcardipine 100 mg OD after the loading dose. On the other hand, for P2Y12 inhibitors, for clopidogrel, we will load with 300 mg stat similarly, followed by 75 mg OD. For ticagrelor, the loading dose will be 100 mg stat, followed by 90 mg BD. So the duration of DAPT for NSTE-ACS patients, right, with or without PCI's interventions, is recommended to be up to 12 months unless there are contraindications. Next, we'll be looking at the anticoagulant therapy. So how do we choose between fondaparinux, also known as Arixtra, or enoxaparin, also known as Clexane? So these two are actually different drugs, though both are anticoagulant therapy. For fondaparinux or Arixtra is actually factor 10 inhibitors, whereas on the other hand, for enoxaparin or Clexane is actually a low molecular weight heparin. In practice, our first line anticoagulant therapy will be subcut Arixtra or fondaparinux 2.5 mg stat and OD. And also the durations of this anticoagulant therapy has been recommended to be 8 days or during the duration of hospitalizations. In practice, normally unstable angina, the anticoagulant therapy will be given up to like 3 days. For non-STEMI, it will be 5 days. For STEMI as well, it will be 5 days. But however, for any reason, the patient need a extended hospitalization, accept bleeding complications, this anticoagulant therapy might be extended until discharge. So to highlight to you, when the patient eGFR is less than 20 ml per minute, the use of Ericstra is contraindicated. Again, in practice, when the patient eGFR is below 30, we will tend to switch them over to the taxane, also known as enoxaparin renal dose, which is defined as 1 mg per kg OD. For example, a patient is 60 kg, then the taxane dose will be 60 mg OD for patients with a reduced eGFR less than 30. Another important drugs in ACS management would be these ACE inhibitors or these angiotensin II receptor blocker. In practice, ACE inhibitor will be the drugs of choice unless there is contraindications to ACE inhibitor. Then only we will consider using angiotensin II receptor blocker as an alternative. So what are the benefits these drugs confer? So they have been well proven that they will be able to prevent the adverse cardiac remodeling, and other non-cardiac benefits are also observed if the patients have other comorbidities as well. For example, it's a proven drug with anti-proteinuria effects, and also it offers renal protection effects in diabetic as well as hypertensive subjects. So these two tables give you the very commonly used ACE inhibitors or angiotensin II receptor blockers. So for ACE inhibitors represented by perindopril, the starting dose is 2 mg OD, or it can be higher, depends on the patient's blood pressure. The target dose is always 8 mg OD. So another alternative or another agent will be ramipril, depends on the availability of this drug in your institution. So let's look at these angiotensin II receptor blockers. They are represented by losartan, telmisartan, or irbesartan. For losartan, the starting dose is always 50 mg OD. Again, it depends on the patient blood pressures because it has the blood pressure lowering effects. The targeted dose is always 100 mg OD. For your information, ACE inhibitor or angiotensin II receptor blocker are absolutely contraindicated in subjects with renal artery stenosis. In practice, we do not routinely screen patients for renal artery stenosis by the means of renal Doppler. However, there's an alternative to it, which is we will perform a renal profile 2 weeks after initiations of these two drugs in patients who are naive to these two agents. So within 2 weeks after initiations of these agents, when you repeat a renal profile for these subjects, you should look at the creatinine level and also the potassium level. In a normal subject, the serum creatinine raise shouldn't be more than 30% from baseline, or the eGFR reduction shouldn't be more than or equal to 25% from the baseline. Equally important, you must look for hyperkalemia in the subjects after initiation of these two agents. If it were proven that any of these have happened, then you need to ensure that this is not purely because of ACE inhibitor or ARB, and at the same time, you need to consider withholding these two agents and to investigate further. Another anchor drugs in ACS management will be beta blocker. So what benefits do they confer? They help in decreasing the patient heart rate, which indirectly will reduce oxygen demand. That will improve the mismatch that I mentioned to you in my first or in the earlier slide. It will also increase the diastolic time. As you know, the coronary reperfusion time actually happens during the diastolic phase. So this will cause improved coronary artery refueling and perfusion. Lastly, it also protects our subject from a post-MI cardiac arrhythmias. I listed here the commonly used cardioselective beta blockers, bisoprolol, carvedilol, as well as metoprolol. So let's look at bisoprolol. Starting dose is 1.25 mg. Again, it depends on the patient blood pressures. We keep in mind that the agents are ACE inhibitor, ARB, beta blocker, all have BP lowering effects. If the BPs cannot tolerate such agent, then you may have to consider discontinuing or cutting down the dose. Okay, coming back. So the targeted dose for bisoprolol is 10 mg OD. The target here is to keep the resting heart rate below 70 beats per minute. At your free time, you can read up this article where they have proven that subjects with a resting heart rate below 70 beats per minute actually fares a better outcome compared to the counterparts that who don't. Another important agents that we need to start for patient ACS would be these lipid modifying agents. This table summarizes to you nicely what are the available statin therapy that we are using. Broadly, they can be divided into low intensity statin, moderate intensity statin, and also high intensity statin therapy. For patients with cardiovascular complications or events, they must be put on high intensity statin therapy. In other words, if they were on these two modes of therapy before that, they must be escalated. For example, to atorvastatin 40 mg on night, or as tolerated, or rosuvastatin 20 to 40 mg on night. Nowadays, in clinical practice, we always talk about treat to target. So what's the target in these ACS patients? So the targeted LDL cholesterol should be less than 1.8 millimole per liter, or preferably less than 1.4 millimole per liter. If that can be achieved, then you at least aim a reduction of at least 50% from the baseline. The lower the better, according to our CPG. If the patient's LDL cannot be brought down despite maximally tolerated therapy, we may consider adding other non-statin therapy, for example like ezetimibe or PCSK-9 inhibitors. Next, we'll be looking at the commonly used anti-anginal drugs. We'll start off with the nitrate first. Okay, this will be first represented by this glycerol trinitrate, also known as GTN. I'm sure that most of you have heard about this drug with sublingual GTN, but just to give you a bit more information, this sublingual GTN will be asked to take as a, one tablet per time when they have a chest pain, maximum 3 times at 5 minutes interval. So in other words, if the chest pain still persists after 3 doses at 15 minutes time, the patient will be advised to go to the nearest hospital for assessment. And so most importantly, please take note that the onset action for sublingual GTN will be within 1 to 3 minutes. So in the history, we always ask, how fast did the chest pain be aborted by this sublingual GTN? At least it let us know, whether is it truly an angina or is it a non-cardiac ischemic chest pain. Another forms of this GTN will be in this liquid form. On this right-hand image, it demonstrates to you what an IV GTN ampoule looks like. Again, it can be used in the patients with persistent angina, and then not commonly, this drug sometimes can be used to control the patient blood pressure as well. For example, patient came to you with hypertensive emergencies or urgencies. Another agent will be isosulfide dinitrate. Again, it exists in two forms. So for the liquids or the isosulfide dinitrate solutions, I think this drug is not being used in HDA because we use IVI GTN most of the time. But in other hospitals, we might use this IVI isocat, which is actually isosulfide dinitrate. Again, it can be titrated accordingly to improve the angina. For the tablet isosulfide dinitrate, will be best represented by your tab isodiol, be commonly given in the 10 mg TDS dosing. Again, the onset of reactions will be most rapid given in the IV manner, which is within 1 minute. For the oral tab isodiol, the onset of actions will be around 30 to 60 minutes. The last nitrate agents I would like to talk about would be this long-acting isosulfide mononitrate. As the name suggests, it's a long-acting drug, hence it can be prescribed on an OD dosing. The most commonly prescribed agent for now will be this Imdo XR in the ward. So Imdo XR is actually a trade name for these medications. In the subsequent slides, what I'm going to discuss about are those add-on anti-anginal drugs. In other words, it means that if the patient does not respond to your first-line medications, then you may consider adding on these few medications. The first add-on agents that I will explain to you will be this ivabradine. The trade name is Coralent, if you ever heard about this. So the indication for this ivabradine is when the patient heart rate remains uncontrolled despite being on the maximum doses of beta blockers, or when the patient is unable to tolerate beta blockers for any reasons, for example because of the blood pressures was too low to even start beta blockers. The caveat is that this medication, despite its very good usefulness in patients with ACS patients, it can only be used in patients with sinus rhythm. In other words, patients with underlying AF are not suitable for these medications. So the benefits of ivabradine are more or less the same as beta blockers. It reduces the heart rate, it will reduce oxygen demand. Again, when you reduce the heart rate, prolong the diastolic time, then you improve the coronary artery refilling and perfusions. In addition, this drug has also been proven to be able to improve the ejection fractions of patients post-ACS events. This table illustrates to you what are the initiation dose for ivabradines. It depends on the patient age. If the age 75 and above, we tend to start with a lower dose with 2.5 mg/BD. If the age is less than 75 years old, you can actually start the patients on 5 mg/BD. And we always reassess the patient heart rate within 2 to 4 weeks and adjust the dose accordingly. And the maximum dose for this medication will be 7.5 mg/BD. The last agent that I would like to mention will be trimetazidine. The trade name is Wasral and ranolazine. These two agents are a bit unique compared to the other drugs that I mentioned to you because the mechanism of action is actually directly targeting the ischemic cardiac cells via free acid oxidation inhibitions. So the downstream effect is that it will be able to improve the myocardial cells metabolisms, which would indirectly improve the patient's angina symptoms. I would like to spend this slide to introduce to you some drugs with known cardiovascular benefits. What I mean is this drug will have the potential to reduce the risk of major adverse cardiovascular events. Some of you may not have heard of this drug or may not be so familiar with this drug. However, I must stress that it's important for you to get familiarized with this drug because I'm very sure in the years to come, this will become the standard of care. The first drug that I would like to introduce you will be sodium glucose cotransporter 2 inhibitors, also known as SGLT2 inhibitors. Example of drugs from this class would be empagliflozin, dapagliflozin, and etc. The second drugs that I would like to bring forth would be glucagon-like peptide 1 receptor agonist. In short, it's known as GLP-1 receptor agonist. Example of drugs from this class will be liraglutide, dulaglutide, and etc. So for GLP-1 receptor agonist is actually an injectable diabetic drugs. The last class of drug will be a drug that is beneficial for patients with heart failure. So this drug is actually known as angiotensin receptor neprilysin inhibitor. In short, normally called as ARNI. So a very commonly used one will be sacubitril valsartan. I hope at this point you'll be able to appreciate that what are the important agents that you must include during the first line treatments, and always be mindful about pill burden, and always talk to your patients, counsel them, explain about the importance of medication compliance, and also always adjust the medication based on the patient requirement, also the patient need. And also, I would like to mention that patients with ACS, they will also undergo cardiac rehabilitations, and most importantly, lifestyle modifications, and also modifying the other risk factors. This slide provides you a very brief overview on how do we go around the cardiac assessment. Essentially, every patient should be risk stratified into low risk, intermediate risk, high risk, and very high risk. In any case, if they are low-risk patients, then we will actually consider doing non-invasive cardiac assessments upon discharge, where they can either do an exercise stress test. Keep in mind that patient that you order ESD, they must be able to run the treadmill. In other words, they must have good exercise tolerance in the first place. If not, then you can consider other stress tests like dobutamine stress echo or CT coronary angiogram and so on. If any of these non-invasive tests came back positive, then we'll refer to the regional PCI for further interventions, for example, angiogram. Other than that, any patient with intermediate risk and above, we will refer them to the regional PCI center for further evaluation from the outset, be it to be done urgently, semi-urgent, or electively, will depend on the patient risk. If you are in any doubt, you can always refer to a regional PCI center or discuss with your specialist regarding the further actions. As I promised, we're going to discuss about some missteps in ACS management at the final part of the talk. So basically, this is just served to highlight to you. It's very important for you to look at the ECG carefully because some of these high risk ECG changes or high risk unstable angina non-STEMI changes, right? The answer actually lie in the ECG. For example, patient with potential left main coronary artery disease or left main stem disease, they would manifest with abnormal ST elevation in the AVR lead. So if present, then you need to consider refer this case to a regional cardiovascular center for early revascularizations. The second scenario would be that you might miss out Wellens syndrome if you are not aware of the typical Wellens syndrome ECG patterns. This is very important because patients with Wellens syndrome, they might potentially have an undiagnosed left anterior descending artery disease, where it needs an urgent or early revascularization therapy in order to prevent the risk of developing an extensive anterior myocardial infarctions in the future. I will end the slide by showing you two ECG. So in this ECG, the main highlight is to show you that this patient actually has ST elevation in the lead AVR, and also he had a concomitant diffuse ST depression from V3 until V6. So in this case, we are consider the possibility that the patient may have a left main stem disease, where a consult to regional cardio referral was made for this case. This is the second and also the last ECG that I would like to show you. I would like to bring your attention to this section of the ECG, where you can see there is a deeply symmetrical T inversion over the anterior part of the ECG, extending from V2 until V6. So what I'm suspecting is actually could this be a Wellens type B? So again, such cases need to be referred to a regional cardiovascular center for further intervention. Thank you for staying until the end. I hope this video has helped you in understanding this topic better. As usual, we always hope that you can support this channel with your subscription in order to keep this channel growing. In the next video, we are going to discuss about safe transfusion practice, and stay tuned, and we look forward to see you again in the next video. Thank you.